Hello, this is Dr. Thomas again. Today we're going to be discussing another very important topic in clinical medicine, namely renal function testing. Overview of renal function. The following are the primary functions of kidneys. Filtration. Kidney filters approximately 180 liters per day of plasma. It selectively retains essential substances. It actively eliminates waste products. Kidneys have some very important endocrine functions, including synthesis of erythropoietin, renin, and activation of vitamin D. Kidneys play a very important role in bicarbonate regeneration and acid excretion. Functional anatomy relevance. Glomerulus is the primary filtration barrier and is size and charge selective. Tubules fine-tune filtrate composition. Interstitium is the site of inflammatory processes affecting function. Glomerular filtration rate. The gold standard test for GFR measurement is inulin clearance. Why inulin? Because it is freely filtered, not reabsorbed, secreted, or metabolized by the tubules. Thus, the amount filtered equals to the amount excreted. Therefore, inulin clearance directly reflects GFR. Impractical for routine clinical use. The equation to calculate GFR using inulin is urine inulin times urine volume divided by plasma inulin. Clinical surrogates of GFR. Creatinine-based estimation. Limitations of serum creatinine-based estimates. Creatinine level is muscle mass dependent on age, sex, and race. There is non-linear relationship between creatinine and GFR. It is a late marker. 50% nephron loss occurs before creatinine elevation. CKD EPI equation. Race independent. Most accurate for adults. Next is MDRD equation. It is less accurate at higher GFR levels, still used in some laboratories. Cystatin C. Its advantages include less affected by muscle mass. It is an earlier marker of GFR decline. Better cardiovascular risk prediction is possible. Limitations. It is more expensive, affected by thyroid disease and corticosteroids, and it has limited availability. Combined creatinine cystatin C equations. Most accurate eGFR estimation is possible with combined creatinine cystatin C equations and recommended for confirmatory testing. Proteinuria assessment. Physiological basis. Normal protein excretion is less than 150 mg per day. Glomerular barrier has size and charge selectivity. Tubular reabsorption occurs for low molecular weight proteins. Testing methods. Dipstick analysis detects primarily albumin. It is a colorimetric reaction. Proteinuria assessment interpretation. Trace proteinuria means 15 to 30 mg per deciliter. 1 plus means 30 to 300. 2 plus means 100 to 300. 3 plus means 300 to 1000. And 4 plus means more than 1000 mg per deciliter. Limitations of urine dipstick method. It is concentration dependent. False positives occur with alkaline urine, especially when the pH is more than 8, and with concentrated specimens. False negatives occur with dilute urine and with non-albumin proteins. Albumin creatinine ratio, abbreviated as ACR. KDIGO classification. A1 is normal and is less than 30 mg per gram. A2 suggests A2 is moderately increased, is 30 to 299 mg per gram, and A3 is severely increased, and is more than or equal to 300 milligram per gram. Clinical advantages: corrects for urine concentration, random sample acceptable, and it is a preferred screening method. Protein to creatinine ratio, abbreviated as PCR. Detects all urinary proteins, useful when non-albumin proteinuria is suspected, and normal value is less than 150 milligram per gram. (24-hour urine collection). Indications: baseline quantification in nephrotic syndrome, monitoring treatment response, and as part of research protocols. Comprehensive CKD staging. GFR categories G1 through G5. G1 is normal and GFR is more than or equal to 90. G2 mildly decreased with a GFR of 60 to 89 ml per minute per 1.73 meter square body surface area. G3A mild to moderate increase and represents 45 to 59. G3B moderate to severe decrease and the corresponding GFR is 30 to 44. G4 severely decreased, represents 15 to 29 ml per minute per 1.73 meter square of body surface area. G5 is kidney failure with a GFR of less than 15. Albuminuria categories: A1 less than 30 milligram per gram, normal to mildly increased. A2 30 to 299 milligram per gram, moderately increased. And A3 more than or equal to 300 milligram per gram, severely increased. Risk stratification metrics. Higher categories including G4 and G5 as well as A3 indicate faster progression risk, higher cardiovascular mortality, need for specialist referral, and earlier intervention requirements. Advanced renal function tests. Tubular function assessment. Fractional excretion of sodium, otherwise known as FeNA. The formula for calculating FeNA is urine sodium times plasma creatinine divided by plasma sodium times urine creatinine multiplied by 100. Clinical applications. If the FeNA is less than 1%, it indicates pre-renal azotemia. If it is more than 2%, indicates intrinsic renal disease, usually ATN. If it is 1 to 2%, it indicates intermediate, and consider clinical context. Limitations. Diuretic use invalidates results. Use fractional excretion of urea if on diuretics. Urine concentrating ability. Water deprivation test. If urine osmolality goes above 800 milliosmoles per kg, it is a normal response. Clinical utility is limited due to patient discomfort and risk. Specialized biomarkers. Neutrophil gelatinase associated lipocalin, abbreviated as NGAL, facilitates early AKI detection, usually within 2 to 6 hours post-insult, predictive of need for renal replacement therapy. Kidney injury molecule 1, otherwise abbreviated as KIM1. It is a tubular injury marker, elevated in acute and chronic tubular interstitial disease. Factors affecting creatinine. Increased production occurs with high muscle mass, recent meat consumption, rhabdomyolysis, hyperthyroidism, certain medications such as trimethoprim and cimetidine. Decreased production occurs with malnutrition, advanced age, amputation, liver disease, muscle wasting conditions. Proteinuria interpretation challenges. Causes of transient proteinuria. Exercise usually resolves within 24 hours. Fever, dehydration, emotional stress, orthostatic proteinuria, and urinary tract infection are some other causes of transient proteinuria. Confirmatory testing requirements. Need 2 positive tests 1 to 2 weeks apart. Exclude transient causes. Consider first morning void for orthostatic proteinuria. Clinical applications. Diabetes mellitus screening recommendations. Annual albumin creatinine ratio screening starting at diagnosis in case of type 2 diabetes or 5 years post-diagnosis in case of type 1 diabetes mellitus. Target albumin creatinine ratio less than 30 mg per gram with ACE inhibitors or ARBs. Microalbuminuria predicts cardiovascular events. In the setting of hypertension management, proteinuria indicates target organ damage. Albumin to creatinine ratio more than 30 mg per gram warrants aggressive BP control, guides antihypertensive medications. RAS inhibitors are preferred. Preoperative assessment. eGFR less than 60 increases perioperative risk, used in contrast nephropathy prevention protocols and medication dosing adjustments. Drug dosing adjustments. Renally eliminated medications are adjusted based on eGFR, not serum creatinine. Consider active metabolites. Monitor for accumulation toxicity. Monitoring and follow-up. CKD progression monitoring. Frequency based on GFR category. G1 to G2 annually, especially if other risk factors are present. G3A every 6 months. G3B every 3 to 6 months. G4 every 3 months. And G5 monthly to every 3 months. Rapid progression indicators. eGFR more than 5 ml per year. More than 25% eGFR decrease, sustained increase in proteinuria, or development of active urinary sediment are rapid progression indicators. Emerging technologies and future directions. Point of care testing include portable creatinine analyzers, smartphone-based analysis, real-time monitoring devices, novel biomarkers, beta-2 microglobulin for tubular function, fibrosis markers for predicting progression, and inflammatory markers for mechanistic insights. Artificial intelligence applications help in the following situations: pattern recognition in urinalysis, predictive modeling for progression, integration of multiple biomarkers. Clinical pearls. eGFR and proteinuria are complementary, both needed for complete assessment. Creatinine is a late marker. 50% kidney function can be lost before elevation. Always consider clinical context. Muscle mass, age, and medications affect interpretation. Confirmatory testing is essential. Single abnormal result insufficient for diagnosis. ACR is preferred over dipstick for proteinuria screening and monitoring. Early detection enables intervention. Slowing progression is more effective than treating end-stage disease. The following are the references. Thank you for listening.